So you've seen this slide before, and I just want to mention again that it's a high prevalence, low severity neurodevelopmental phenotype. And we discussed this previously. It does, the difficulties, neurodevelopmental difficulties often exist in combination, and there's no growing out of deficits with a strong persistence into adolescence, and even like a growing into deficits when you think about executive functions. I think the other important part is, as we have heard already from Neil, it's not the surgery. We see many of, especially the motor difficulties already prior to surgery, indicating and correlating with the prenatal alteration in brain development. So I could actually go from here directly to the interventions, but I really want to make kind of a loop to what we have discussed this morning. If you want to understand how to prevent it, you really need to understand the mechanisms. And the slide I will show you now really summarizes what has been said this morning. So or that's at least how I try to think about it, and actually this graph increases as we all learn more about the mechanisms. So Sarah, thank you so much for this wonderful talk. You really kind of set the stage for and explained the contribution of genetic mutation, de novo mutation, and known mutations for altered brain development and the neurodevelopmental phenotype. And I think we all agree, if we have a child with congenital heart disease that has a genetic diagnosis, the outcome, the trajectory of outcome, the neurodevelopmental phenotype will dramatically change if that's, let's say, a known genetic abnormality. So I think what we will focus now on, and have already focused when we talked about the neurodevelopmental phenotype, is really children where we do not have a clear genetic diagnosis. Reduced brain oxygenation, I will pick up from the input you gave, Neil, on hyperoxygenation. I will talk about that. So that's a field of intervention potentially. And you just very nicely alluded to the heart placenta brain connection and maternal stress. And I will show one study that addressed this mechanism leading to altered brain development. And then, of course, we have the whole surgery, perioperative period. Neil has said a lot about this, the combination or the accumulation of risk factors or of adverse risk factors post-operatively really contribute to outcome, but the explained variance is really rather low, but there's a cumulative effect on that. And I will focus on the socioeconomic background of the parents and how significant that is on outcome. So you already heard about this very important and interesting study performed by Steve Miller and Mike Seed on the continuous low-dose maternal supplemental oxygen in fetal single ventricle. And this study has just been, or has been published a year ago now, where it's a single center open label phase 1 safety feasibility study, 25 pregnant women, supplemental oxygen starting at 29 weeks for 16 hours a day. What has been shown is that the good part is no medical complications, but also no improvement in MRI-assessed fetal oxygen delivery, brain injury, or neurodevelopmental outcome at 18 months. So no real benefit of that intervention. And then, you already mentioned this very important study, the association of elevated paternal psychological threat, altered fetal brain and offspring cognitive and social emotional outcome, the group of Kathy Limperopoulos. Importantly, this study included healthy mother-infant dyads, and what they could show that the prenatal maternal stress strongly determines or is associated with infant cognitive performance, and that this is mediated by hippocampal volume, and the gyrification index actually impacts later outcome. And because this knowledge has been around for a while, even before we knew it also affects brain development, this group by Erika Sood presented this study 3 years ago, where they decided to deliver a psychosocial intervention for mothers who carried children with congenital heart disease, and they could show that this virtual intervention to improve, to reduce maternal stress was actually effective and increase parenting self-efficacy. So there are studies around that target maternal stress during the pregnancy and are feasible and show effect. I will not talk that much about perioperative risk factors and neurodevelopmental outcome because that has been already shown. But what do we know about the brain development, and especially how does brain alteration predict neurodevelopmental outcome? This has also been discussed previously. So the mechanisms of perioperative brain injury are multifactorial, have different onsets prenatally with brain dysmaturation, then delayed network development, and also associated with this altered and delayed network development, a higher risk for perioperative brain injury. And as has been mentioned, this is called encephalopathy of congenital heart disease. Now, I think the difficulty or the importance here is that we often see mild, small white matter injuries, small strokes. We usually don't see like large injuries like a media infarct, strokes. We see smaller abnormalities. So it's not like in hypoxic ischemic encephalopathy where we see, let's say, the grade 2, according to Sarna, or 3, severe changes in deep gray matter and white matter. The changes are more subtle. They are clearly more prominent and larger in the subgroup of children with hypoplastic left heart syndrome. And so it really depends on the population you study. I will show you now a very elegant systematic review summarizing what is available in terms of MRI, perioperative MRI, and how that predicts outcome. This is a very nice way of showing the correlation between MRI assessment, the timing of the MRI assessment. So just have to switch my banner, whether the MRI was done pre-surgery, post-surgery, the study here, what type of MRI was done, and whether it had a correlation with, and you can see here the outcome is usually 1 or 2 years, where the assessment of neurodevelopmental outcome is rather, let's say, crude, because we do assess early markers or early stages of development. And you can see green bars indicate that there is an association between MRI changes, usually injury type, white matter injuries. And you can see some studies show a correlation with early neurodevelopmental outcome, but most assessing longer outcome, like 6 years of age, do not show an association. There's only one study by Natalie Klessens that showed an association, and those were children with aortic arch obstruction. So there's quite some heterogeneity in terms of correlation with outcome. And that's true also for volumetric changes. So while I fully agree that doing an MRI perioperatively is very important, pre and post surgically, to really assess whether there has been preoperative changes, alterations, the predictive value of MRI is quite limited at this point. So let's go to this very important period or this important factor, socioeconomic status. As has been said, it's one of the strongest, most important determinant of neurodevelopmental outcome. In the normal population, with a range or a change of almost 20 IQ points in this study we did, correlating MRI findings with outcome which were negative, so there was no MRI association with 6-year outcome, but socioeconomic status was strongly associated with outcome, with this difference of 20 IQ points. And we've seen this over and over again in at-risk population, but also in normally developing children. And we are talking about a Swiss population, quite homogeneous population. And despite this, we see such a strong effect. And then the second part, there is an interaction. So the effect of congenital heart disease is modified by socioeconomic status over age. So the older the child is, the more pronounced the impairments, the effect of congenital heart disease on cognition becomes when you come from a low socioeconomic status background. They all start kind of lower than normal, half a standard deviation. When you do a Bailey at 1 year, so 7 points on the Bailey, but then you see this kind of fanning of outcome with a catch-up and a compensation or resilience, whatever you want to call it, for the high socioeconomic status group, and kind of growing into the neurodevelopmental difficulties in the group with low socioeconomic status. And this has been demonstrated by others, by the group of Serena Council, where they showed that one of the components of this dramatic impact is if you have a cognitively stimulating parenting environment, so showing the children books, being involved in plays, reading to them, the Bailey score increases significantly. Again, same effect, 20 to 30 points in this group with CHD. And they showed the same for executive function. And lastly, I want to mention the role of maternal mental health and family functioning. Melanie Ehrlich could show that over the period in this very elegant longitudinal study we did, we could identify a group of mothers who had a resilient phenotype in terms of maternal mental health. They had very good maternal mental health, and a group that had persistent low maternal mental health over a period of 13 years, using this latent class analysis, growth analysis. And it was associated with behavioral outcomes at 10 years. And we talked about, do all children have the same phenotype? No, they don't. Also, Melanie could show that there's a favorable profile and showing children at the age of 13 years with very good executive function, IQ, and behavior. And here again, better mental health, maternal mental health, and more positive family functioning was associated with a more resilient profile. So what do we have to do? We have to establish neurodevelopmental follow-up programs, because early detection will allow us to identify those at most risk. We need to collaborate with primary care providers who also help us to identify these children. Then we need to treat the neurodevelopmental impairments according to the domain. We know that. So the earlier we identify them, the more we can target them. And that's, you know, in my clinical work, common knowledge. So physical therapy, occupational therapy, speech and language therapy, or, you know, depending on the symptoms, we treat them specifically. I think it's important when children grow older to collaborate with educators, school systems for early detection. And when we take this really seriously in terms of family social factors and family stress, we really have to target those families with social risk factors, so lower socioeconomic status, and target those even if they have no or just subtle neurodevelopmental abnormalities. I know this is the hardest part because it's harder maybe to get them into the clinic, but I think we need to do a better job in really addressing these families. And then I think the second thing is really to screen for symptoms of parental stress and impaired family functioning. So it's really the families, how they enter basically your clinic, how they do, that will probably show the largest impact if we can help them and target their difficulties. And I think because of time constraints, I think I will stop here. And I'm happy to answer questions.